Uh, I would just like to say that we live in North India, which is one of the most populated regions in the world. We breathe more than 25,000 times a day, and it is unimaginable the harm of pollution can cause to our body and respiratory system. Our next talk is about healthy aging of lungs, which I feel has been the most neglected organ of the body until COVID happened. So the talk will be presented by a senior and renowned chest physician over 20 years of experience, and for all those living in Delhi, this talk would be of much interest, I am pretty sure. So for the next talk, I would like to first call upon the chairpersons, Dr. D.K. Garg, the ex-medical superintendent of Rajan Babu Institute of Pulmonary Medicine and TB. Sir, if you may please. Thank you. Can we have a round of applause, please? And our eminent speaker, Dr. Chandermani Panjabi, a senior physician and critical care physician from Mata Chanan Devi Hospital, New Delhi. Please, sir. Thank you.
I'm sorry, दिल की बातें करते रहे सभी दिल की बातें करते रहे सभी फेफड़े का कुछ बताया ही नहीं फेफड़ा भी बड़ा स्वाभिमानी निकला गुस्सा था पर जताया ही नहीं गुड मॉर्निंग नाउ I welcome Dr. Chandermani Panjabi. He is a senior consultant in Mata Chanan Devi Hospital. He has got experience of 25 years. Over to Dr. Chandermani Panjabi, please.
So at the outset, I would like to thank Professor V.P. Bansal for inviting me here, and very good morning to all of you. And it's my proud privilege to be here. So my talk is about healthy aging of the lungs. Since morning, we have been talking about aging, and we should know how our lungs age in a healthy manner so that we can take care of them. And since we are living in one of the most polluted area of the world in North India, so we have to ensure that our lungs age. All of us want to age gracefully, without any disease, without any complications. So in the next 10 minutes or so, I shall be talking about how the healthy aging of the lungs happen and what we should be aware of. So my talk is based on the various effects of age on the respiratory system. Anatomical changes happen, mechanical changes happen, the ventilatory changes happen, perfusion changes happen, and lastly immunological. There was a mention about inflammaging, so immunological will be talking about inflammation which happens in the lungs. Amongst the anatomical changes, calcification of costal cartilage and sternum occurs. Most of the orthopedicians know about it. Degenerative changes in the spine and rib articulations leading to kyphosis, and as we age our posture becomes like this. We can see the wedge shaped vertebra, and if you look at the curvature of the spine, the shoulders start drooping. So this is what we need to prevent. Japanese came up with the term sarcopenia or locomotive syndrome. They are doing a lot of work on it. Unfortunately, not very much known in India about it. But we all know that the bone and muscle mass reduce by 2% every year after the age of 40. The AP diameter of the chest increases, and from the normal chest it can become a barrel shaped chest even without underlying COPD disease. The respiratory muscles are in a mechanically disadvantageous position, especially after the age of 60, and decreased force generation by the muscles is there. So it leads to increased work of breathing. Amongst the mechanical changes, there is loss of elastic fibers of the alveolar ducts, and the alveolar elasticity is lost. Loss of destruction of supporting structures of the lung parenchyma occurs. Premature closing of the airways occurs, leading to hyperinflation, most commonly seen when the patients develop emphysema. But even in normal adults, some degree of hyperinflation is occurring. Decrease in the elastic recoil, decrease in the chest wall compliance, and progressive decrease in the respiratory muscle strength, which is usually mild if we are maintaining a good diet and exercise pattern. The decrease in the elastic recoil of the lungs leads to decreased expiratory flow and narrowing of the airways, decrease in the FEV1, decreased closing volume, decrease in the forced vital capacity. If you look at the parameters on the pulmonary function testing, there is an increase in the functional residual capacity and the residual volume. However, the tidal volume of the lungs usually does not change. Why so? If you look at this graph, as the age advances, The residual volume and the functional residual capacity are increasing. The vital capacity is decreasing. However, the total lung capacity is not changing much. Why it remains unchanged? Because two factors are countering each other. The decreased elastic recoil makes the lungs to expand. So due to hyperinflation, theoretically the TLC should increase. However, the increased chest wall stiffness and the decreased motor power causes the TLC to decrease, so the net TLC does not change. So this is what we should be careful about. The diaphragm is the most important muscle of respiration, and as we age, the diaphragm also weakens. Unique adaptations are there in the diaphragm compared to the limb muscles. It has got greater fatigue resistance, type 1 muscle fibers, increase in the mitochondrial density and oxidative capacity, and diaphragm is the muscle with the maximal oxygen consumption, and the capillary density also is very high, which augments blood flow up to 4 times more than the limb muscles. So as we age, this function of the diaphragm starts going down, and then we start feeling short of breath. At the age of 20, we might be able to run a mile without any problem, but at the age of 50 or 60, running a mile causes us to pant and get short of breath. So with aging, change in muscle type occurs, decreased type 2 fibers are there in the diaphragm, the respiratory muscle senescence also occurs, and the diaphragm becomes more plastic. So the elasticity is lost, which leads to increase in work of breathing. The first figure shows the normal elastic recoil of the lungs, and as the curvature of the diaphragm reduces, there is a decrease in the elastic recoil of the lungs. Regarding the perfusion changes, the loss of elastic fibers in the alveolar ducts leads to a decrease in the alveolar capillary surface area, decrease in the pulmonary blood flow volume, decreased diffusion and increased dead space ventilation, which leads to a ventilatory perfusion mismatch. And after the age of 60, 10 to 12% increase in oxygen consumption is there. So this diagram shows the ventilation perfusion mismatch. There is an increase in shunt, the lung collapses due to changes in the closing capacity, and as I had shown you on the pulmonary function testing, the functional residual capacity was changing. Increase in the VQ scatter occurs due to the poorly ventilated basal lung regions, which receive large fractions of pulmonary blood flow. So the perfusion and the ventilation mismatch occurs, and also the alveolar dead space increase contributes to this, and we can see the red curve is the blood flow and the blue one is the ventilation, and there is a mismatch there with increased blood flow in the dependent regions, which are atelectatic, where there is no ventilation. So we need to counter this mismatch by regular exercise, healthy lungs, avoiding pollution, good diet, and ensure that this mismatch does not increase to cause problems in our daily activities as we age. Regarding the inflammaging or the immunological changes, if we do the bronchoalveolar lavage, increased neutrophils, IgA, IgM can be seen. These are all inflammatory, and decrease in the macrophages are there, which are actually protective. If we see, there is a lot of toxin production, increased T lymphocytes, release of superoxides, and persistent low grade inflammation. And this is the basis for why we need vaccination in elderly. We need influenza vaccine so that the influenza antigens do not affect the lungs. This persistent low grade inflammation will lead to damage to lung matrix and impaired gaseous exchange, and also the decrease in the epithelial lining fluid, which is rich in antioxidants, will increase the susceptibility to environmental toxin. Environmental toxins will include pollution, noxious gases, cigarette smoke, and the viruses. So influenza virus will also be included in the environmental toxin, and as it has been said, it is endemic in our country. So what we need to do to counter this aging? I have told you about how the lungs are aging. We need to have some degree of exercise training. It is not that we need to go into a bodybuilding competition and go and become an athlete, but some sort of aerobic training or sub-maximal exercise. 15 minutes of walking daily for 12 weeks in a 70-year-old has shown to cause 7.7% increase in the minute ventilation, decreased breathlessness and work of breathing, which is achieved by decrease in oxygen consumption. So this is all what we need. 15 minutes of some sort of aerobic training without any strength training or without lifting heavy weights almost every day. So it is approximately 100 minutes in a week. This is what we want for ourselves. We can do some sort of yoga, we can do various forms of pranayam like Kapal Bharti, Alom Vilom, etc. If we do maximal exercises and weight training, if we are able to do after the age of 60, that is either 10 minutes of running at least 5 days per week or lifting heavy weights, target should be to achieve 170% of maximum heart rate. But many of those who develop cardiac problems in the elderly after the age of 60 will not be able to achieve this. So for them, the sub-maximal exercise would be sufficient. But for those who can do this, they can double their increase in minute ventilation from 7.7 to 14%, and this is achieved by increase in the tidal volume and not the respiratory rate. So minute ventilation is the multiplication product of tidal volume and respiratory rate. So we are not increasing our respiratory rate, but we are increasing our tidal volume by weight training exercise or by running at least 5 days a week. So depending on our capability, either we can do 15 minutes of walking daily or we can do 10 minutes of running to maintain our lungs. But then again, the walking and running should not be in a polluted area, or it should not be very early in the morning when the air is full of environmental toxins. So it should be usually after 7 a.m. or 8 a.m. or we tell the patient half an hour after sunrise you should go for your walk or running. How we can adapt? Avoid smoking, avoid exposure to respiratory irritants, participate in physical exercise to increase the lung function, obviously with physician guidance so that you don't fall more sick after exercise. Stay active and engaged in daily life. There was a lot of talk about being active on social media, etc. Being sedentary increases the risk of respiratory mucus production, muscle weakness and lung infections. And last but not the least, stay informed. So thank you very much for your patient listening, and any questions I will be happy to answer.
Thank you, Dr. Chandermani. Hello. Thank you, Dr. Chandermani, for an excellent lecture. Now I'll invite the questions from the audience, please.
Can there be a paradoxical situation when a patient of COPD, these patients have hyperhemoglobinemia?
Yeah, so hyperhemoglobinemia is very common in COPD and in smokers, and it is said that these patients COPD, there is a lot of emphasis now on pulmonary rehabilitation, because these are the patients whose lungs are not healthy, so they may not be able to do exercises like this as has been said. So there is a pulmonary rehabilitation program for them. They will do spirometry exercises, breathing techniques will be explained to them. If they have a lot of mucus production, then postural drainage has to be explained to them so that they let out their mucus every morning and it should not collect. And gradually, as the oxygen consumption of the lungs decrease and the hyperinflation reduces, the hyperhemoglobinemia will start coming down. About 30 years back, there was a concept that any COPD patient who has a hemoglobin of more than 16, 350 ml of blood should be just let out from the vein. It was called letting of blood, and every 3 or 4 weeks or every 6 weeks this should be done. But now this concept has been done away with because this was not showing any advantage. So what is advantages now is for COPD patients to do some sort of training of the lungs and some sort of pulmonary rehabilitation so that these effects are obviated.
Right. And when we are running on the treadmill, you were talking about heart rate. So how much of increase in heart rate should not frighten us?
Sir, any exercise will increase the heart rate by 15 to 20%. If the lungs are healthy, we can target a 70% increase. That is, we can go from 100 to 170 or we can go from 70 to 120. But if we have a disease, then we should always consult the physician that how much is allowed, especially those who have got underlying cardiac problems, so that arrhythmias do not occur or heart failure does not occur. But for a normal individual, up to 70% increase in the heart rate is said that it should be achieved on the treadmill. But again, then we have to be cautious. Or if we are feeling any symptoms or breathless, we can shorten that from 70% to 50%. Routine, normal, sub-maximal exercise, 15 to 20% heart rate definitely rises.
So I have one suggestion and one question.
Yes, sir.
The suggestion is regarding my mother's prescription, that you put mustard oil in both the nostrils, and it prevents infection going to the lungs and all. So your take on that, number one. And number two, about PND, post-nasal discharge, which occurs very frequently in elderly patients. Thank you, sir.
Yes, sir. So, sir, very good questions. And I think putting of mustard oil in the nostrils still in many households, especially small babies, जिनको जुकाम लग जाता है, the grandmother, when the baby has slept, quickly applies mustard oil on the nostril. I think it will not cause any harm. And even in elderly population, if people are doing it regularly on a daily basis, there is some science to show that it might help. Some people are also using eucalyptus oil also instead of the mustard oil. And secondly, regarding the post-nasal discharge, yes, with aging, there is atrophy of the sinuses, and it leads to vasomotor rhinitis. And post-nasal discharge is very common, and these patients should be evaluated by the ENT specialist. And if required, they should be put on long-term intranasal sprays to decrease the secretions and to counter the post-nasal discharge. Because post-nasal discharge during sleep position can lead to aspiration pneumonia and lot of other side effects. That the mucus is trickling down the back of the throat into the airways, especially if the person is not sleeping in the left lateral position and sleeping without a pillow in the supine position. Another thing which Dr. Suresh Bansal mentioned was about the sleep apnea syndrome, that in the elderly, when people are snoring, their airway become choked, and again this post-nasal discharge can add on to that.
Hello, Dr. Chandermani.
Yes, sir.
Is it advisable to put mustard oil in the nostrils?
Outside, just over here, there are some studies. Even in COVID, when we were reviewing the literature, I was the nodal officer of COVID at the hospital. There were many theories coming up that this will prevent the inhalation of the viruses. But it has been found not to have any harm in it.
Sometimes it may lead to pneumonia also, something like that.
Gets, coated,
Yes.
and the viruses and the bacteria, they do not go.
Yeah, it is just that applying on the nostrils, not that we should instill drops inside.
Just
Applying outside on the nostrils, just with the thumb and the finger. That is what was advocated in COVID also. Many people were doing a lot of various formulas and home remedies for COVID.
So not like nasal drops.
Not like nasal drops.
So we'll take one last question, sir, before we'll conclude the session.
Thank you very much. Sir, it was a very enlightening
Thank you.
lecture. Now, in the COVID era, the maximum impact was on the lungs.
Yes, sir.
Some of the elderly survived, some of them didn't. But are there any long-term effects of COVID?
If you read the literature now, unfortunately in India we are not doing studies. I am also getting many of my patients. There is a term called long COVID syndrome, and it has more than 71 symptoms in it, and 17 different diseases have been identified. Many patients who had COVID briefly, they had the virus positive but no symptoms, and for a few days, and then they were in home isolation, and then now after 1 or 2 years they are having symptoms. They are having cardiac problems, respiratory problems, psychiatric problems, multiple other problems.
Are there any preventive measures that one can take?
Preventive measures, all has been said, is social economic support and emotional support to all, because post COVID many people have gone through a lot of emotions, either mentally, physically, emotionally, etc. But in the US, all the patients of COVID are being followed up by the government with every 6 months to 1 yearly annual checkups to find out what changes have occurred. Sometimes they might be exaggerating. If a patient has a myocardial infarction 1 year after COVID, it is being labeled as long COVID syndrome. Whether it is true or not, we do not know. Just because the person had COVID does not mean abhi heart attack ho gaya, so it can be associated with COVID. Could have happened without having the COVID infection also.
One last question. The role of aspirin in preventing further.
I think the cardiologist would be able to answer that question
take
about
that up at the cardiology
aspirin.
session,
So
please.
there is a talk by Dr. Neeraj Bhalla. He would be able to answer whether preventively each one of us need to take aspirin or not,
One
or it
quick
is
question,
only for
sir.
a select population.
Hello, sir.
Yes.
Is Pulmonary Society or Critical is taking any, long COVID, prolonged COVID studies? Why it is not being done? I just
I think we do not have a
India
database, or the patients are very, very scattered with everywhere, but definitely we should be doing that. We should collect our database, we should call back those patients, give them questionnaires, ask them about their activities of daily living, has their lifestyle changed or not. Lot of things have to be done.
Thank you, sir.
I think,
if Dr. Garg could present to.
So with age, size of the thoracic cavity decreases, the muscle strength decreases, and the cuff strength also decreases. Immunity also comes down. So we should be very, very careful. I'll end the talk with a couplet. दिल का क्या है, ये तो टूटता है, जुड़ जाया करता है. ए फेफड़े, तू अगर नाराज हो तो मौत की तरफ मुड़ जाया करता है. थैंक यू.
Sir, please. May I please request Dr. Suresh Bansal to felicitate our chairperson, please.